section of electricity, because you talked about all the stuff that was there, the rhythms that you had to know, atrial fibrillation, ventricular tachycardia, AFib. Sudden cardiac death is essentially that patient has no cardiac history, and all of a sudden is found unresponsive with no rhythm. And that's usually one of the lethal arrhythmias, which is pulseless VTAC or VFib, is usually what that person presents with. So the thing about it is even though we see that the person comes in, or we saw that they actually had VFib, it was something that was documented on an AED, because you can't interrogate those machines that tells you what rhythm the patient had when they were diagnosed. Doctors tend to, when you come in and the person has sudden cardiac death but no history, what we really work them up is for a rhythm problem. So the sudden cardiac death is more than likely, 75% of those are electrical related. So it's something with the conduction system of the heart that's the problem. 25% of those are MIs. But you know, we're so used to working people up for a heart attack, they're going to do that first, and then they go to the EP study. But sudden cardiac death is usually, by far, 75% of it is electrical, and 25% of it is an acute MI. But you're going to see both workups end up happening for the patient. The thing about it is that you can work up the MI quick. So that's a lot of times why they'll do that, because if a person has a heart attack, unfortunately they can have symptoms days before and are still having a problem, and that's why they end up, a couple of days later passing out kind of things. But you can use lab work to figure out what's happening with the patient, so you can see that going. But sudden cardiac death was the only other thing that I wanted to make sure we mentioned in that. The medications that you can see on the patient, all that will be the same, and then we talked about some of the other drugs you can use, kind of stuff you got to look at for your patient. Pretty much just kind of know that anytime you use an antiarrhythmic drug, even though you give it to correct the problem that a patient has, it can cause other arrhythmias. And if you're using more than one, it can be problematic, because a lot of times you'll do that, especially if you have a person that you're using something that's going to control their rate, but they also have heart failure. So you may be giving a patient cardizem, but then you may also be giving them something like one of the beta blockers or something like that, because that helps with that kind of thing. Or you may give a person an ACE inhibitor. Those things can actually end up potentiating effects of each other. So you got to be careful. It's always about, you're on that seesaw to figure out whether or not I can maintain stability in this patient, maintain cardiac output, all that kind of stuff, but that may be things that you see on your patient. But just know in your head that even though it may treat whatever rhythm we see at the time, sometimes it ends up causing problems later on. So that's why we try to figure out why the patient is having the problem, as opposed to just giving just drugs. And that's all we do. I'm just going to give you drugs and never try to figure out anything. I always want to figure out what's happening with the patient. But that's essentially the electricity piece that is there. Okay? Know what the atrial fibrillation looks like. So when you describe it, it's no distinct P wave and irregular QRS complexes. When you're talking about VTAC, that's going to be a patient who has wide, bizarre QRS complexes, because remember that QRS complex is supposed to be narrow, and when it's wide, it tells you that there's a conduction defect in the ventricles. So those are things that tells you that's what you're going to see in a VTAC rhythm. And then, of course, it can exist with and without a pulse. If you're going to use electricity, cardioversion is live rhythm, defibrillation is dead rhythms. So that's the basic stuff about electricity. If you know that, you got that down. Seriously, that's all. It's not going to be asking about all those other rhythms that can happen to a patient, because those are the ones that you need to be able to address. AFib is because it's common. VTAC and VFib because it's usually the complication associated with patients having cardiac problems. That's the worst case scenario of things happening with that. So that's why you see those. Okay. So then we had our structural piece, or things that happen because there's something that happens with structure. So the first thing you got to understand is atherosclerosis. You know what? Maybe I'll do that tomorrow, because I can do that the whole day. We'll do hypertensive crisis and heart failure. Because then we'll finish that heart failure. Now these don't go together. I'm just writing this over here so I know what I'm talking about. Because y'all know I'm retired. All right, now MP2 we talked about hypertension. It's the blood pressure medications your patient takes. So we know hypertension is considered the silent killer, right? Because most people who have hypertension don't know they have it. Okay, so all of a sudden you look at your family history though, because some people can do everything right and still be hypertensive. So you have a strong family history, because no matter what, in all these cardiac things, there's always going to be things to talk about as far as lifestyle modification for the patient. What are those risk factors that put people at risk for cardiovascular problems? So age is one, ethnicity is one, gender is one. If you think about those things that are modifiable versus non-modifiable. Non-modifiable, those things we cannot change. Even if you try or put it on paper, it's still the same. All right? So age, gender, ethnicity, those things are non-modifiable. No matter how much you try, you know, because you have people that have gender reassignment, but your DNA is still male. So that's how it's going to look at as far as risk factors for things. So just know that that's the kind of things you got to talk about patients about changing. Those modifiable risk factors are things we can change. Sedentary lifestyle, diabetes, hypertension, if you do have it, that you're controlling it, doing the things that you need to do to make sure those are things that you take care of in the patient. Because those will always be teaching points. Because you know a patient always going to ask you, why did I get this? Right? Why did I have this aneurysm? You got to think about it. A lot of it is the underlying piece of atherosclerosis, but it's part, how do you control that? Making sure blood pressure is under control, control your cholesterol, all those kind of things are patient teaching points. Okay? So you got to look at those risk factors that patients have. So hypertension and all the cardiovascular diseases all have the same kind of risk factors as far as modifiable versus non-modifiable. So that's the patient teaching piece that goes with that. All right? But then we talk about hypertension, most of the time people don't know. So they end up, make their diagnosis, then we try to do some things. You know, if you're talking about the things that we should do in real life, it doesn't always happen, right? Because the first thing you can do is change your diet and lose weight. You know that works for how long? A couple of weeks. You do really great. Doing everything you're supposed to do. Then it kind of falls apart, goes by the wayside. You still may be doing the little things like you're supposed to do, but if you get a 10% weight loss, it's going to help you with your blood pressure, better glycemic control. Those are things that are truly, patients don't understand how big a difference it can be just losing 10% of your body weight. But it really does make a difference. So when patients lose a lot of weight, you end up coming off meds. That's why that ends up happening, because your body works more efficiently, blood pressure's down, all that kind of thing. But that's what we're really supposed to do, is say, hey, you need to go home and try to lose some weight and stop eating salt. You know, certain times of the month, you just got to eat salt. Guys don't have it. Y'all just want salt when you want it. But sometimes it's like you need salty stuff for life, okay, kind of thing. So those are kind of things you got to think about sometimes. But you got to make those modifications. Send them home and tell them, hey, I need you to eat a low-salt diet, which means limit processed foods, canned foods, that kind of thing is where sodium comes from. Then they'll tell you, oh yeah, I was doing great. I got a low-fat meal on top of it. Low fat is always high sodium. You got to do something to make it taste good now. So it's usually high sodium. So if you look at those, anything that's low fat has really high sodium content. Fat tastes lovely. Just saying, it makes stuff taste good, so that's why it does that. But patients will tell you that all the time. So low sodium diet, look for hidden places where you have salt because you don't really think about it. You know, all of your condiments, most everything is high in sodium. People don't think about it. You know, my nephew and my niece are going to have heart disease. I just know it because they love French fries, but they also love ketchup. If they don't have ketchup in the house, they lose their mind. They sit by until their mother goes to buy it. Seriously, they'll sit by the pantry and go like, Mom, when are you going to go get the ketchup? And they'll have their own. If you go to take them to the restaurant, they get a handful of ketchup. I'm like, really? What's wrong with that? But that's the kind of stuff they do. So I just know it. But most condiments have a lot of sodium in it. So that was a hidden source for people. They don't really think about it. They're going like, yeah, I'm not eating this, but I'm doing this other stuff. So you have to be careful with that. So that increases vascular volume. So therefore it raises blood pressure. That's the reason why you have low salt intake for people. You also have people that have that renin-angiotensin-aldosterone system going on. It tends to happen more in Caucasian people. African Americans don't produce a lot of renin. So that's why certain drugs don't work for us as well. So when you think about it, I know you don't have to choose it, but a lot of times you think, why does this person start on this medication for hypertension and this person starts on another. It all has to do with genetics and what works best for people. So renin-angiotensin-aldosterone system means I have angiotensin 1, that is a potent vasoconstrictor, released in the blood, causes a clamp down in the periphery that's going to raise blood pressure even more. I have the release of renin, which has to do with aldosterone and sodium in water. Water is retained in the body, vascular volume goes up, raises blood pressure. So when you have renin-angiotensin-aldosterone system activated, it's like a dog chasing the tail. It continues the process, keeps raising the blood pressure over and over, kind of thing. Now the bad part, even worse about that, is that that process starts to make changes within the body itself. Changes the myocardium. The heart already has to work harder. Remember this when we talked about hypertension. Heart works harder, so the muscle gets bigger over time. So if you don't control that blood pressure, heart's going to get even bigger. The inside of the chamber is going to get bigger, hold less fluid. So that's the ventricular remodeling piece. Cardiac output is going to go down. So it's an end result of poorly controlled hypertension over time, is that you're going to have a person with poor cardiac output. So that's why we give the medication. Stops that process from happening, stops the remodeling in the heart. It's going to help with, yes, it's going to lower blood pressure, but the other thing it does is help as far as ventricular remodeling, to increase cardiac output. So that's something that you see, especially in heart failure patients. That's why it's part of therapy now for heart failure patients to be on low dose if they have a low blood pressure ACE inhibitor for that reason. Okay. So you can have that happening in your patient. All right, so that's the whole process of hypertension. When we talk about hypertensive crisis, and this is the part that don't get so bogged down in your textbook, because we're going to talk about the patients in hypertensive emergency, hypertensive urgency, you're thinking about the end result problem, hypertensive crisis. Usually happens because a patient has withdrawn their medication, meaning that for some reason I stopped taking my meds. And so then my blood pressure goes up again. But this time I see an acceleration in the blood pressure. So not just do I have the 150 over 90, I may have 240 over 120. But it's usually associated with patients who stop taking their meds. And the big culprits are alpha blockers. Now you know alpha blockers are not first-line therapy to treat blood pressure, right? Because we usually use either a diuretic first, so that's the potassium-sparing diuretics we give to people to increase vascular volume, lowers blood pressure. If that doesn't work, we can use beta blockers, which are normally what we use for Caucasian people, because it works better for them. And so we can do beta blockers for them. We can also do ACE inhibitors. African Americans tend to get calcium channel blockers because that's what works for us. So just know that whatever drug you use for a person, whatever it is for that patient, it's just they've been taking it routinely and all of a sudden I decide I'm not going to take it, or maybe it's too expensive. If it was, you know, if you were taking the drug I take, that might be a thought process. But I don't want to die, so I just take my drug. I know it works for me. I take Lotrel, a combination drug, but generic doesn't work for me. I have to take brand. $2.93 a month I take for one pill, for 30 pills. Yeah, I want to die. All right? So you know how many purses that would be? Kind of thing. But I want to be here for a little while. I'm already retarded. So if I wasn't taking it, I'd be more retarded, have a stroke. And a trach. And I'm going to die. So I can't do that. Yep. All right? So we can't do that. So those are the kind of things you got to think about. So you have to, that's a lot of times too when your patients are taking meds. The first thing my doctor asked me when I started taking this medicine years ago now, but first thing she asked me is, your insurance company going to pay for it? Because I know this will work for you. I see it work for patients. So my blood pressure was down within the first week of taking medication, and it stays down in the 110s. That's why I take it. When you give me generic, I'm still 140. So to me, it's like, what am I taking the drug for if it doesn't work? And the insurance company always fighting me about this. And we fight back and forth. I'm like, well, I'm about to come through this one now, kind of thing. But there are some patients that don't fight for their own thing. You know, but that's what you got to do. But hypertensive crisis usually happens because a person's been taking their meds, all of a sudden they decide, I'm not going to take it. Too expensive, I'm not going to do it. Or whatever it is. Because sometimes it's other things. If you take a calcium channel blocker, one of the things that people really don't like on the guy's side is that it can cause erectile dysfunction. You're like, well, if that don't work, I ain't taking a pill. Now the thing about it is you would not want to have a stroke, but they'll do that. Seriously, they will come tell you. I used to see people in the office, and they're like, man, I can't take this. You always know what it is, because when you switch to drug, they don't ever want to see you. They want to talk to the man that's in the office. When it's stuff like that, they don't want to talk to you about it. They want to come to you when it's time to do the prostate exam because your hands are smaller. But that's it. All right? Other than that, they don't want to talk to you about those things. So they're not taking their meds. But the thing about it is this acceleration in blood pressure. Blood pressure gets really high. Hypertensive crisis means you're not feeding organs. So think about everything is damaged because they're not being perfused. Because think about, even though your blood pressure is high, you're clamping the vascular system, so that means eyes don't perfuse, kidneys don't perfuse, brain doesn't perfuse, heart doesn't perfuse. You're thinking about the same process. It's a different process, but the end result is the same. Think about the diabetic, retinopathy, nephropathy. It's not the same mechanism by which it happens, but the end result is the same. If I'm not perfusing vital organs, they die. So when you have hypertensive crisis, you're thinking about end organ damage. What are those things that need perfusion in the small vessels, large vessels? So the retinopathies, the nephropathies, the neuropathies, those are all things that you look at. So for that person who has hypertensive crisis, the end result thing is that kidneys die off. So I'm looking at BUN, creatinine, urine output on the patient. I'm looking at glomerular filtration rate, because those are things that tell me these kidneys aren't perfusing. Urinary output going down and down, blood pressure going up and up, I worry about hypertensive crisis, because I'm killing off those kidneys. When it's not feeding my brain, changes in level of consciousness, person may have a stroke. If it's not feeding the heart, then I'm going to have myocardial ischemia. Those are all things that are happening as a result of this person having impaired perfusion because their blood pressure is so high. Blood pressure high does not feed anything. That's how you have to think about it. Blood pressure is how you think, oh, it should just move the blood along. That's not the thing that's working. It's constricting the vasculature in the small vessels. So that means anything that's fed by those small vessels dies off. So that's what you're looking at, end organ damage. Patient tells you, I can't see. That may be permanent because they now have retinopathy associated with that. Those are things you don't ever want to see happening in your patient. You want to reverse this process. So I got to lower the blood pressure. You already know, hypertensive crisis, I need to bring the blood pressure down. But the other thing you cannot do is bring it down too quickly. Okay, so it's an incremental decrease that you're going to see in a person's blood pressure. Now, even though we have all those antihypertensive meds and that kind of stuff that we use, because we talked about ACE inhibitors, beta blockers, ARBs, calcium channel blockers, all that kind of thing, when you have hypertensive crisis, the drug of choice is a nitrate, and it's going to be nipride. Nitroprusside is the name of the drug. That's the drug we use for hypertensive crisis. And patient goes on a drip. You're going to monitor their blood pressure. And yes, we look at systolic and diastolic blood pressure. But the thing that guides your treatment is the MAP, mean arterial pressure. I need to make sure organs are perfused. Minimum perfusion to those things that your body needs. So that's what mean arterial pressure looks like. Part of the reason why it's so important, and I tell basic students especially because they haven't had this experience yet, the reason why it's so important to be able to know how to do a manual blood pressure on a patient is because you know that Dynamap you keep pushing around from room to room. Every time you do a blood pressure on it, it calculates the MAP for the patient. But the true blood pressure you should do for or take for the patient should be a second one. Because the MAP has to calibrate for that patient the first time. The second time is the better blood pressure for the patient. How many people do blood pressure in the room? They go and they put it and they go to the next person. So if you really wanted a true measure of what's going on with that person's blood pressure, do it that way. But remember, if a person's blood pressure is really high or really low, those things don't register as well. So doing a manual blood pressure is important. There are nurses that don't even know how to do it. If you actually told them to go put a blood pressure cuff on a patient, locate where you need to listen to, they wouldn't know how to do that. And when you got a blood pressure that's really low especially, that's going to be more accurate than a Dynamap any day, because you know how they go, that noise when it can't get anything. That's what it's doing because it can't calculate it. Those are things that people go like, I don't know, I can't get a blood pressure. That's like, If the patient not talking to you, that's a problem. If they're talking to you, you may have it all wrong or something happened with the machine, I can deal with that. But when they're not talking to you, there's something going on. You need to do something different. So you need to check that blood pressure. But incremental lowering of the blood pressure, so the person's going to be on a drip. But we're going to look at blood pressure. We try not to lower them more than 10 millimeters per hour as far as talking about their blood pressure. So I wouldn't want somebody who was 240 over 120 and the next hour have them 120 over 60. That kills people. The same way that you would if the blood pressure stays high. The issue becomes is that you drop the blood pressure too low, then it also causes decreased perfusion as well. It's a kind of a thing that's crazy, but that's what you don't want to do. So 10 millimeters of mercury you want to do in about an hour. So you're going to put them on a drip, continue to monitor the patient, lower it slowly. You look at both, yes, systolic and diastolic blood pressure, but the true measure that you look at is MAP, mean arterial pressure. If it gets below 60, bad stuff. Body isn't perfusing vital organs. That's what you worry about. When MAP is too low, you're not perfusing, just like if the person had hypertensive crisis. And way back when, how we used to bring people's blood pressure down real quick, because you used to see it for hypertensive crisis, and we did it for patients who had autonomic dysreflexia with spinal cord injuries, is pierced procardia. You know, the little gel-like procardias. We used to stick holes in those and squeeze it under a person's tongue. Would drop a blood pressure in a minute. It really would. But then they start having chest pain. Yeah.
So the MAP is below 60 is when problems start?
Yeah, because you're not perfusing vital organs when MAP is that low. You need just that, just to be laying down doing nothing. The minute you move, you need more money, you need more pressure. So if I was just laying flat doing nothing, just breathing, and that was a low rate of breathing. Heart rate is normal, that kind of thing. You could sustain that, but everybody's moving and doing something. So that's why you need more perfusion than that. Okay, so mean arterial pressure is what you need for that. Okay, so that's going to guide your treatment of hypertensive crisis. But you're looking for end organ damage. So that means BUN creatinine, urinary output, glomerular filtration for kidneys, actual visual acuity when you're talking about eyes. Somebody tells you that. When the heart, you're looking for EKG changes, complaints of chest pain, possibly positive troponin, myoglobin, those kind of things tell your patient has a heart attack. You're looking at those things happening with your patient. And then neuro-wise, you're looking for stroke. So you're looking at orientation, level of consciousness, mentation, those types of things. But that's the hypertensive crisis. It doesn't happen a lot, thank goodness, but when it does happen, you need to treat it for the patient. The book goes into great detail talking about whether it's emergency, urgency, that kind of thing. Your thing is to focus on the complication piece, because you can know it happens. Most of the time it is happening in relationship to patients not taking their meds. It can also happen to other things too, because we have people with secondary kind of weird stuff. Some of the endocrine disorders can cause it, but most of the time you see it because patients don't take their meds. And the big culprits are alpha blockers. It can happen with any drug, but those are the drugs we see it most often with. So making sure that patients understand, take your medicine all the time, whether you feel better or not, because you know that's what it is. They felt bad the first couple of weeks, start taking their meds, they feel better, and now they stop taking their pills. I had a friend that just started doing this, and I just want to hit him. I used to play golf, so I just want to take a 9-iron and hit him with it. I don't even know what a 9-iron is, but I hit him with it. I heard it, kind of thing, because that's what his thing was. He says, I don't have a problem anymore. Why do I have to take these pills? I'm like, dude, just gonna die. What's going on? What's wrong with you? When people tell me stuff like that, I'm like, really? Now, his thing is, he'll change his lifestyle and do all that stuff for a little while, because that's what he always did. Whenever you tell him something, he's changed his stuff for a while. And then always is sending me things about supplements. Should I take this one or not? Because I'm working out. I don't know what I should do. Because he is not a fat guy, none of that kind of stuff. But it's family history. And sometimes that just trumps everything, kind of thing about what's going on. So you just need to understand that. But that's his thought process. You know, I feel okay, so I don't have to take my pills anymore. I said, okay. Is your insurance paid up? Is my name as a beneficiary? That's all I need to know. Kind of thing. So stop it. All right, but people need to understand that. The other thing we have there is heart failure. Now, this one, of course, is one that you see almost every day you're in a hospital. because heart failure patients is something that happens a lot as the person gets older. So, and of course, we live in an area where you have a lot of old people, so you see heart failure a lot. But it's the end result of, like I said, patients who have poorly controlled hypertension, or patients who've had some type of damage to the myocardium, which you can a lot of times see with heart failure, with the MI, and they end up having heart failure. Okay, so the muscle itself is not able to pump efficiently anymore, so the body can't nourish itself, so the patient ends up having a problem. That's what you see in heart failure. Now your textbook is going to go into great detail talking about high output versus low output, systolic versus diastolic failure, because those are the things that you talk about in relationship to heart failure. What type of failure does the patient have? And when you look at your patient histories, they talk about that in the chart. So that the big thing that you also see as far as for nurses, kind of how we figure it out. Now, don't get me wrong, physicians more do the diastolic, systolic failure. And those are things related to, most patients have diastolic failure. That's the most common type of heart failure you see. But what it is talking about where the blood goes, basically when you're talking about that for the patient. Most people learn right versus left. Okay, although that's not the greatest thing to know, but you can tell by what the structures are and what they do, what the patient looks like, and what you see as far as symptoms. Left-sided heart failure is the most common type of heart failure that we have. Okay. Right-sided failure doesn't happen as often, but it tends to happen more in certain types of people. And it's usually those people who have poorly controlled asthma or COPD when you're thinking about your patients, because that's also known as cor pulmonale when you talk about patients who have right-sided failure. So different things that you look at as far as that goes, but one of the things that kind of make it simpler to remember is think about the structures. Although now they don't want you to learn it that way, it is the easiest way to tell which type of failure your patient has. So left-sided patients are the pink puffer. Remember we talked about that before? So a left-sided person is the pink puffer. So they have oxygenated blood. The reason you call them puffers is because they have a lot of respiratory symptoms.